Can you
I
hear
would
me?
like to thank the organizers of this program for inviting me to present at this conference.
Can you hear now, Machara?
Yeah.
Okay.
I'll be presenting the abstract, treatment response in adult hypertensives attending a secondary healthcare center in Southwest Nigeria. The outline is as shown, which include introduction, research objectives, methodology, results, implication of the study to research and clinical practice, and references. There has been an increase in prevalence of hypertension globally, and the trend towards poor control. The prevalence of hypertension was reported to be 44% in Western Europe, 28% in North America. In the US, blood pressure control was achieved in 48% of hypertensives, while in Nigeria, about 24% had their blood pressure control. Despite the development of new drugs and guidelines in management of hypertension, it remains a difficult disease to control. The failure of adherence to prescribed drugs is a major cause of poor blood pressure control. The truth about modern treatment of hypertension is that most patients regard many drugs to achieve targeted blood pressure levels. The recommendation of the current international guideline, optimization of drug treatment, including the need for prompt initiation of drug treatment, selection of the most appropriate antihypertensive agents, and the use of monotherapy or combination therapy based on the level of blood pressure. Also included is the presence of other cardiovascular risk factors. The predictors of poor blood pressure control, diabetes mellitus, chronic kidney disease, diabetes nephropathy, cerebrovascular disease, lifestyle modifications, efficacious and adequate antihypertensive medication doses. Appropriate drug combinations must be prescribed to have adequate blood pressure control. High prevalence of uncontrolled hypertension has had accompanying morbidities, mortalities, increased burden on the healthcare system, coming close. This study aims to determine the effect of health education on blood pressure reduction to improve patients' outcome. Methodology. The study was conducted at the State Hospital, a secondary healthcare center in Nigeria. The study was an intervention study of 386 patients with uncontrolled hypertension, followed up for 2 months. Respondents were recruited from April 2015 to May 2015 and followed up till July 2015. A simple random sampling technique with computer-generated random number was used for selection of patients. The study population was composed of adults 18 to 70 years with uncontrolled hypertension. The intervention. During the administration of questionnaires to the respondents, at first contact, patients receive essential information about hypertension, lifestyle modifications, adherence to pharmacotherapy. The study was approved by the Ethical Review Committee of Oyo State Ministry of Health, Ibadan, Nigeria. Informed consents were obtained from eligible patients before administration of questionnaires and examinations. Data was analyzed using SPSS version 20. First criteria was used to analyze the association between categorical variables. The blood pressure reduction was analyzed by peer student t-test. A p-value of less than 0.05 was considered to indicate statistical significance. Now let's have a look at the results of the study. 386 patients who met the criteria for recruitment were interviewed. The mean age of the respondents was 57 years. Figure 1 shows level of adherence of the respondents. About 91% of the patients had good adherence, while about 9% had poor adherence. Figure 2 shows the role of hypertensive drug used by the patients. About 40% of the respondents were moderatic, 39% on amlodipine, 31% on amlodipine, 23% on lisinopril, atenolol, adrenaline, propranolol have very few patients on them. Figure 3 shows the number of hypertensive drugs used by the respondents. About 16% of the patients were on one type of drugs. About 45% of them were on 2 types of drugs. 29% were on 3 types of drugs. Those who are taking more than 3 types of drugs were about 10% of the population of the patients. Figure 4 shows distribution of body mass index of the respondents. Only about 3% of the patients are underweight. Normal weight has about 35%. Overweight has 30%, and those who are obese were about 20%. So the population is majorly that of overweight and obese patients. Table 1 shows association of body mass index and systolic blood pressure. A higher proportion of patients who were overweight and obese had high blood pressure compared with those who are underweight and those who are normal. Table 2 shows the relation between body mass index and diastolic blood pressure, just like the case of systolic blood pressure. A higher proportion of those who are overweight and those who are obese had higher blood pressure compared with the underweight and those who are normal weight. But in this case, the association was statistically significant. Table 3 shows the effect of health education on patients with uncontrolled diastolic blood pressure. There was a significant difference between the mean first diastolic blood pressure and the mean third diastolic blood pressure. Table 4 shows the effect of health education on patients with uncontrolled systolic blood pressure. There was a significant difference between the mean first systolic blood pressure and the mean third systolic blood pressure, just like the case of diastolic blood pressure. So this is showing that after 2 months of follow-up with the intervention of health education on the respondents, there was a significant reduction in the blood pressure of the patients. Figure 5 shows that at the beginning of the study, that the patients had uncontrolled systolic blood pressure. But at the end of 2 months, 39% of the patients had their systolic blood pressure control, while 61% had their systolic blood pressure uncontrolled. Figure 6 shows diastolic blood pressure changes at 1 month interval. After 2 months of follow-up, 66% of the patients had their diastolic blood pressure controlled, while 34% of them had their diastolic blood pressure uncontrolled. So those who have the diastolic blood pressure control are higher than those who have the systolic blood pressure control. Table 5 is showing the relationship of blood pressure levels and body mass index. The relation of body mass index with first diastolic blood pressure was positive, weak in strength, and statistically significant. Whereas that of systolic blood pressure was also weak in strength, but not statistically significant. Table 6 shows linear regression for the first diastolic blood pressure on significant variables. As shown in Table 6, for every 1 unit increase in body mass index, there was a statistically significant increase in diastolic blood pressure by about 0.22 units. The predictor of diastolic blood pressure from this table was body mass index. In conclusion, after health education and counseling of the patients at first consult, there was a significant difference between the mean first diastolic blood pressure at first visit and the mean third diastolic blood pressure after 2 months on drugs. Also, there was a significant difference between the mean first systolic blood pressure and the mean third systolic blood pressure. Body mass index was a predictor of diastolic blood pressure. Based on the findings of the study, there is a need to launch a comprehensive approach for educating patients on hypertension, lifestyle modifications, as non-pharmacological treatment are the need for the patient to adhere to their drugs. Limitations of the study and future research. The study was an intervention study, but there was no comparison group and no randomization into groups. It discussed before and after study with health education as intervention. Large-scale randomized control trial will give better results. The study was hospital-based, making secondary generalization difficult, although they also served a very big population. The study was an experimental study, and so causal relationships could be established to some extent.